is one of the most advanced stages of chronic kidney disease, or CKD, and it's essentially when somebody's kidneys are no longer able to function on their own. And so kidney failure with replacement therapy is when those people with kidney failure have a life-sustaining treatment such as dialysis or a renal transplant. And some of the most common causes or associated causes of kidney failure with replacement therapy, or KFRT, is a variety of reasons that range from metabolic conditions such as diabetes to genetic predispositions. And so for this specific study, we undertook it because despite there being a high health burden of chronic kidney disease and subsequently KFRT, we often see that in non-communicable disease policies at a national level, it's not explicitly included. And we also see that there's a lack of fully comprehensive data about the landscape of KFRT. This study was conducted as a part of the Global Burden of Disease Study, or the GBD, and within this specific analysis, we were able to compile data from across a variety of sources, such as renal registries, published scientific literature, and data shared from the GBD Collaborator Network. And once we had all that data compiled together in a systematic and standardized way, we were then able to estimate KFRT prevalence over time and have that also stratified by sex, age, location, and also by associated underlying causes. There are three key findings that I'd like to highlight. So the first is that our study found that there are 5 million people globally that are on dialysis or have had a kidney transplant. And we saw that over time, for the past 3 decades, that number is steadily increasing. The second is that our study also found there to be a wide variation of KFRT prevalence across the globe, where we saw in high-income countries the highest prevalence, and then in low and lower middle-income countries, the lowest prevalence. And it should be noted that this is more likely a reflection about better access to care or better access to these treatments, and not necessarily a lower disease burden in those low-income settings. The third finding is that when we looked at the associated causes for KFRT, we found that diabetes type 2 and hypertension are the leading causes. And even after adjusting for age, we saw that KFRT associated with these metabolic conditions has steadily also been increasing over the past 3 decades. The likely future trajectory of KFRT is deeply concerning. So we know from our study that KFRT prevalence has been increasing over the past 30 years, and this will most likely continue to happen, especially when we take into account aging populations and also increasing metabolic diseases such as diabetes type 2 and hypertension globally. And all of this will be compounded by other aspects such as rising obesity or poor diet and inactivity, which are all contributions to CKD and then subsequently that progression to kidney failure. At the same time, we also know that health systems themselves are stretched very thin, where we know for KFRT care specifically, we see major challenges where there is limited number of nephrologists, organ shortages, and in general underfunded care. So without proactive investment, the gap between KFRT healthcare access and capacity will most likely worsen, and therefore we'll see a concerning trajectory.